from the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
I would like to welcome you back to the second of a 3-week series on healthcare in America. Many of us contend that that's going to be one of the major issues throughout the 1990s. And to assist us in dealing with this subject for weeks 2 and 3, I'm very pleased to welcome to our program Dr. Linda Hotzenbuehler, who is the Dean of Health-Related Professions at Idaho State University. Our guest comes with great qualifications and expertise to deal with this subject. Not only does she hold that position where she daily discusses this and deals with this important issue, but she holds a PhD in clinical psychology from Kent State University. Welcome to our program. We're very pleased to have you, Dr. Hotzenbuehler.
Thank you. It's my pleasure to be here.
And as always, I'm very pleased to have regular panelist Janelle Burke, who is the law clerk to the Chief Judge of the 1st Judicial District in Idaho. And I shall ask Janelle to commence the questioning. And I would add to this, to our viewers, today we're going to be addressing specifically healthcare in America, and then next week with our guests, we will talk about health-related professions and what their role is in the healthcare. And with that, I will yield to Janelle Burke.
To set the stage for our viewers today in terms of healthcare in America, what is the state of healthcare?
Well, it's hard to open the newspaper daily or turn on the national network news without hearing something about healthcare. In other words, the visibility of healthcare has increased significantly in the last 6 or 7 years. And in a nutshell, I would say that everyone is dissatisfied. And there's lots and lots of finger pointing going on. So the consumers are pointing fingers at the doctors and the hospitals, and the doctors and the hospitals are pointing fingers at the attorneys and at the federal government, and so on. And I suppose those fingers are being pointed back at the consumers for not taking sufficient care of themselves. So lots and lots of finger pointing, lots and lots of dissatisfaction, a lot of discussion about the cost of health care and the increasing cost, escalating at a rate that is frightening to some people, and far more of the GNP than we have ever paid in history. And then an evaluation that we're not really getting a bang for our buck. So compared to other Western countries, we're spending a lot more money on health care to no avail, so that our infant mortality rate and some of the other indices of health care in our country don't match other Western nations whose cost for health care is lower.
So you've mentioned one of the things, which is the rising health care costs, but is another problem the number of people who are uncovered, the number of people who don't get medical care?
Yes, and that we call the infamous 37 million. I suppose since 37 million was publicized a couple years ago, it's probably up to 40 million at this point. Those people that we call uninsured, who slip through the cracks, who don't qualify for various national health insurance plans that currently exist. And I always want to remind people that we do have national health insurance. It's just limited at this point to the poor and to the elderly. So Medicare and Medicaid are national health insurance plans. Some people get bristly when we talk about national health insurance, and again, I like to remind them that we already have it. It's just that not everyone qualifies for those plans. So those individuals who either don't qualify for Medicare or Medicaid, nor are they sufficiently employed or employed by people who cover benefits related to health, and slip through the cracks. Those are the 37 million or 40 million at this point that we're talking about.
And can you tell me if my perception is correct, that perception being that more people need health care now than ever before?
Well, I suppose if you're talking about the aging population, that certainly is the case. There's some interesting debate about the aging issue. Obviously, people are living longer.
Right.
We have more elderly now than we ever have, and it's projected that we will continue into the 21st century having more and more older people, and that more and more people will live beyond the year of 100, and so on. The interesting issue on that, by the way, is whether in fact the health care will increase in those individuals. In other words, will we be able, through technology and prevention, which is one of my particular interests, be able to compress some of the illness that occurs in the last few years of life, such that we may not have the explosion that we anticipate in terms of health care.
So what you're saying is that people will live longer, but they may be healthier longer as well.
Exactly. We still end up spending the lion's share of our money on health care in our last year of life. The point is that some people fear, since so many people are living longer, that therefore the burden on the healthcare system is going to be tremendous. And I only point out that that is a matter of debate, that it's not absolutely a sure thing.
I just want to continue on the same line of question that Janelle was doing, and you're so eloquently describing the depth of the problem. And I have some statistics that I have gathered for the program, and I note from those statistics what you've indicated, depending on what's publication you look at, that somewhere between 37 and 40 million Americans have no health insurance coverage. Many people think those are people unemployed, and as you have just indicated, many of the individuals that have very, very low income and are not employed can be covered by Medicaid. Is it not correct that many people who are in those statistics that I just gave are actually employed, but they work for someone that's a small business and do not have coverage?
Or self-employed, or seasonal workers. So there are a variety of people who slip through those cracks. Sometimes health coverage is an optional plan for employers and people who are really tight, have families and so on. Many payments simply cannot afford that insurance, and so they take risks, and that's basically what they're doing. They're playing the odds that no one's going to get hurt or no one's going to get sick because they need the cash flow.
To complicate the matter even more, for those individuals who take that risk or just simply are not covered by an employer, that with one accident or one major illness and surgery, that a bill that one receives today from that care can wipe out everything that you have or even that you don't have. It's easy to have a bill of $50,000 or $75,000 and that you might be paying on that for many years. I have made that comment to look at another statistic, and it indicates in the publication that I'm using that over the last 10 years that medical care has increased 135% faster than the inflation rate. So aren't we reaching a point of crisis in this country that individuals are going to have some kind of protection from those kind of possibilities in their life?
Well, right, and I hope I don't sound like I'm dodging the question
Sure.
or the issue, but that's the point that I brought up before, that the cost seems to be the primary issue underlying the dissatisfaction, that we seem to see the cost escalating at a rate that is very, very concerning, and that's where the finger pointing comes in. The question becomes, why is it escalating so much? Are people literally padding their pockets with this money? If you talk to a physician, he or she will say that part of the increase in their own personal costs has to do with attorneys, okay, because they have to increase their liability insurance. The litigation has resulted in a lot of extra tests, second opinions have to occur, and so on and so forth. So lots and lots of finger pointing about exactly why these costs are increasing. Finger pointing at the federal government. The people talk about the fact that the administration, which is HCFA, Healthcare Finance Administration, the cost of administrating the Medicare and Medicaid program in this state, in this country, is unwieldy and that it should be streamlined significantly. So again, without dodging your question, I'm not sure why the costs are escalating. Clearly they are, and perhaps the answer to why is all of that finger pointing. In other words, each of those people are responsible, including the consumer. The consumer, if they are uninsured, ends up showing up at the emergency room in a trauma situation, which costs much more than going to a primary care kind of clinic early on before the problem becomes a crisis.
I would like to go into one other area before returning to Janelle, and this came up on our program last week, and it had to do with the fragmented system we have in this country with, private health insurance. We have Medicare, Medicaid, and some individuals are self-insured, whatever it may be. Some individuals want to try to analyze this problem by saying that our rising cost of medical care and a larger percentage of our gross national product going to the care is because of a partial national health care program. However, when you look at the statistics throughout the 1980s, we find that Canada, who has such a program, spent 8% of their income or gross national product on medical care. In Great Britain, it was 6%, and in this country, it was 11.5%. With that involved statement, isn't the problem partially directed to the fact that we are, more than other countries, fragmented, going in a lot of different directions, and there is no coordination over either coverage or holding costs down? I mean, as an expert in this area, I'd just like to get your reaction to that particular issue.
I guess I'm not absolutely sure. I know that some of the things that I see as fundamental changes in our current system clearly would result in some decreasing costs. For example, I think it's rather foolish that prenatal care is not universally accessible to all females, and instead we spend literally hundreds of $1,000s life-flighting premature babies to medical centers and then keep them alive, and in fact in some cases end up with physically and developmentally delayed individuals who again cost lots and lots of money to care and educate and so on. Something's wrong with that, with a system that does that. So I think that certain things must be fundamentally changed in this country, and it goes beyond, I guess, or perhaps it's similar to what you're talking about in terms of system change. We don't just have to, I guess, limit the cost, which seems to be the way the federal government has been handling things to this point. The Healthcare Finance Administration, through DRGs and other acronyms that people have become familiar with, PPOs and so on, have tried to limit the cost and the payment either to healthcare providers, whether they be physicians or hospitals and so on. And more than that has to occur. I think we need to significantly change things in terms of the delivery system, not just the payment system. I think there's much too much focus on who's going to pay for all of this. I think that the fundamental changes in the process of healthcare delivery needs to occur first. Then we'll fight about who's going to pay, whether we're going to have a single payer system or whether we're going to have a pay or play system or whatever the lingo is once we get down the road. I think that that's the most important thing that we should be dealing with as a nation first, and then talk about who's going to pay and how we're going to pay for it.
Janelle Berg.
I want to follow up a little bit on what you were talking about, the prevention of medicine, and the prevention as being very economic, very cost-effective in many cases. What are some other examples of areas in which we need to have prevention in addition to prenatal care, for example?
Immunizations. Okay, now some people will argue that immunizations have problems in and of themselves, but I brought some statistics with me today which demonstrate that for every $1 we spend on an immunization, we save about 10.
Okay.
The prenatal care that I mentioned before, every $1 we spend on prenatal care, we save about $7.50. And I think that's a very conservative estimate because it doesn't talk about the long-term cost of a disabled individual who is a premature baby. Alcohol-related accidents and injury cost the state of Idaho in 1990 $80 million. That's just the state of Idaho, and we don't have a lot of people in Idaho. You can imagine what it would be in a highly populated place. Tobacco use is now the 6th leading cause, or it's the cause of death in 1 out of every 6 Americans. And those are preventable kinds of problems as far as I'm concerned. And there's another system change that I think has to happen. And again, it's related to economics and it's related to money. Only very recently have private insurers started to pay for things like mammograms, early detection kinds of tests, well baby, well child, well adult for that matter, checkups. The insurance industry has been primarily focused, as has everybody, on the sick and not the healthy, nor have they promoted preventative kinds of things, and I think that's what needs to be changed.
I have a question though. Sometimes people will, and this is from the devil's advocate point of view, but sometimes people say, well, but they wouldn't take advantage of it anyway, even if it was available. Is that true? Or do people actually tend to take advantage of it once it becomes available?
Oh, I think so, and I think that my example before of where the sore throat turns into a significant problem, or the ear infection turns into a significant problem, and the person ends up in ER. In the emergency room at a very high cost, which, by the way, most insurance companies and all of the federal programs will pay for. But not necessarily the well baby, the well child checkup, which can detect those things earlier. So we've got to make some system changes. I've got another one which might upbraid some of your viewers. I think that we need to change the way health care is delivered in terms of the personnel also. Right now, we have a shortage of physicians in the state of Idaho. We're one of the lowest, if not the lowest, physician per capita in the country. And as in all places, we are also maldistributed. In other words, in some of our places, our more rural areas, we have no physicians whatsoever. A couple of things I think need to happen about that. One is we need to increase the number of what we call primary care physicians instead of the specialists. And so we need to give incentives for people to go into primary care. At this point, being a specialist tends to be the preferred route to go if you are a physician. You tend to make more money that way. Although the new relative value scaling, I don't know if you're familiar with that term, as of January 1992, HCFA implemented relative value scaling as a way of paying physicians, and what that did was decrease the discrepancy between primary care physicians, which are people like family practitioners, pediatricians, internists, the gatekeepers on the healthcare system, who tended to get less money or less payment for their services than some of the specialists, the highly trained specialists, and the gap there has been narrowed somewhat. At any rate, I think that we need to develop a system whereby more people are encouraged to pursue primary care medicine. Secondly, I think that primary care can be delivered by non-physicians who are trained not to the level that physicians are, but can do initial assessments and evaluations, and then only upon referral do physicians need to see cases. And so I think, although people don't like the word mid-level, people like physician assistants and nurse practitioners can be employed in this country to a much greater degree than they currently are, and that would clearly help us, as it already does in some cases in our very rural, remote areas where physicians do not reside, but either nurse practitioners or physician assistants have been handling health care in some of the remote areas. Pierce appears a good example of that, which has been serviced by nurse practitioners over the years. So those are some fundamental changes. I would even extend that to dentistry, so that my hope in the 21st century is the first person I see is a dental hygienist, and only upon referral will I see a primary care doctor.
The points you're making are just so significant and could help us get a check on some of the problems, I think, and you've articulated those very, very well. An article I have by James Garcia also indicates that there's fraud in some cases, like in every profession, and when there's money involved, that can happen. The statistics he gave just astounded me when I heard those, and I'll get you to react to them. He indicates that annually there may be as much as $75 billion in fraud and abuse in charging and collecting in the process. With your work in the field, does this seem like a reasonable statistic, and how would we reach that as another way of correcting the cost of medical care?
Yeah, I'm not quite sure how to correct it. I, in fact, can relate to it in that I understand some of the hospitals who are struggling to survive given the implementation of DRGs and PPOs, and so may be accused of fraud because they are trying to regain some of their costs. In other words, from their perspective, and if you get a hospital administrator in here, he or she will be able to explain this far better than I, but from their perspective, they are not receiving from the federal government adequate funds for Medicaid and Medicaid patients to cover their costs. And so if they are billing inappropriately, as far as someone is concerned, whoever wrote that article, that would be certainly not from their perspective, or they'd just be trying to recoup their losses, and that's very different. From their perspective, it's called uncompensated care. Now, I'm not saying that hospitals do this and are part of what's going on there, but it's a very different perspective from someone truly falsifying records, perhaps saying that patients had been served at a particular facility, or a doctor had served a patient when in fact he or she had not.
If I could just interject, that's what he is speaking of.
Yes.
Not what you're talking about, but where a doctor would indicate that they had provided service and they had not. In fact, the U.S. Justice Department, the FBI recently did an investigation in which a number of people were arrested, and even some of the witnesses indicated that they were asked to even go get prescriptions and so forth when they really and give them back to the caregiver.
And
so.
Clearly that is illegal, unethical, and professionals of that nature should no longer practice any profession, no matter what they are. But I do know that there's a lot of indictment against healthcare facilities for changing a designation here or there on a patient because it's a better way of there's more payment coming for one service versus another, so there's a lot of finessing that goes on there. But again, from the facility's perspective, it's a way of recouping some of their uncompensated care, which is a very different angle than direct, straight-out fraud. Yes. Most of the professionals that I work with and that I'm familiar with, I trust are ethical kinds of providers, and I have no patience for the other kind.
Yes. One final question before going back to our panel, and you see statistics, and I have some with me that indicate that it can be as high as 24 cents out of every dollar for health care can go into administrative cost. Is there any, that's a very high percentage compared with some other professions and services. Is there any way getting that under control? You've already addressed some issues in relation to that, but are there other things that could be done in that arena?
Well, as an administrator, I know that administration costs money. And I don't honestly know how to streamline. And when you talked early on in the show about a need to coordinate, to me coordinate means administrate. So if we come up with better coordination, quote unquote, it may end up costing us more money, at least for the administrative part of the care, and less for the actual hands-on delivery of the care. There is a model of currently being promoted by the American Hospital Association, which talks about community networking, which is an attempt to get communities to design some kind of coordinated service, and it would be decided based on the uniquenesses of each individual community. I'm not familiar enough with the program really to give you details about it, nor to even define what they mean by community. I don't know if Coeur d'Alene is a community, or if Kootenai County is a community, or if Northern Idaho is a community, but at any rate, that is a model whereby some kind of coordination does occur. And again, coordination means somebody's got to be organizing it, which is a little bit different than hands-on suturing and surgeries and delivering babies and prescribing medicines and all of those things. So I don't know how you coordinate and at the same time decrease administrative costs.
Janelle Burke.
Just a quick question. Why should I care? If I'm covered and if I have my own primary care physician that I'm very satisfied with, why should I care about the rest of the people in America and what's happening to them?
Well, you also, you might care as a citizen not only of America but of Kootenai County, because the county has an indigent medical fund, and your property taxes fund that particular fund, and people who are unable to pay for medical expenses receive money from that particular fund. As that money is paid for medical expenses, then the pie is only so big, so the monies don't go for other kinds of things that you think it should go to, for new roads and bridges and all the other things that your property taxes pay for.
We have about 1 minute left, and I would like to ask you in that minute that we have left, and you've certainly addressed so many issues, but if you could say to our viewers what you think is the number one problem in health care, what would you identify that to be?
Well, yeah, I've listed two things that I would like to, well, I can quickly name three. One is I think that we need to use more have access to more primary care, not necessarily delivered by physicians, but other people that I call mid-level professionals. I think much more attention ought to be paid by the American public toward prevention. And the third thing, which I haven't had time to talk about today, is that I would like to see a closer coordination or melding of the education system and the health system.
I promise you, as I interrupt, that we'll come back to that as we start the program next week with you. Thank you very much for being with us today. It's been outstanding. And Janelle for her outstanding questions. Ladies and gentlemen, please join us again next week at the same time, and we will continue our discussion with our guest, Dr. Linda Hudson-Buehler, and we will talk about what I just left off with and also the health-related professions. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Telemedia Services on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station.